they were not only performed in almost all women who were COVID-19 positive, but under indications that were nothing but excuses, and almost all women received the procedure in this period. Obstetric interventions, where they are properly indicated, are beneficial for the health of women and children. In this case, they are unquestionable. Evidence is clear that C-section rates above 10% do not reduce maternal mortality or perinatal mortality. Nevertheless, cesarean rates keep increasing, but access to cesarean is strongly determined by socioeconomic and cultural conditions, which show that women who would require a C-section do not have access to it, while there are women having access to it with no need. Those evidence are clear, and yet the impact at the long term of this way to be born is started to show evidence that must make us increase our knowledge and be cautious in its indication. I hope this webinar may help to narrow the existing knowledge gap on these subjects. Once again, welcome. Thank you very much for your participation. It is a wonderful way to commemorate CLAP's 15 years, to go on advancing knowledge, to go on providing technical cooperation to countries, and with a permanent dialogue with academic institutions in the region, health ministries, civil society, so that we may strengthen the capacity of systems to protect the health of women and children. Thank you very much. Thank you, Dr. Barbosa, for your welcoming words, and also for providing a framework on the inequity of access to technologies, including cesarean section. We shall now give the floor to Dr. Susan Saruja. Susan is the director of the Latin American Center of Perinatology, CLAP, which is celebrating its 50th birthday. And she will talk a bit about the 50 years and where we are standing right now with a video. So Dr. Susan Saruja has the floor. Good morning to all of you. Be welcome to this webinar. Thank you very much, Dr. Jarvas, for your words and for your time in this meeting. We know how busy you are, and we also know of the importance of your support to this subject in the region. I wish to welcome all of you to this third webinar. We are going to discuss today something that is fundamental when we think of the care of women and newborns, which is what CLAP does. We shall discuss the transcendental moment of delivery. We are all able to remember the deliveries we had, or our partners if we are men, and we know of the importance of that time in every family life. That is what we are going to discuss today. More than ever before, we are looking forward where, as far as we can go with our knowledge, how much have we helped women and newborns, and to what degree do we have to be careful so that technology always acts in a positive way, a bit like what Dr. Jarva said, so that it cannot have negative repercussions. We shall listen different presentations on that in the morning. But I wanted to tell you that all this discussion also looks forward to the future, thinking that we have to take some values such as women's autonomy, the discussion of other technologies, and what we could do. But right now, I would like to show you the other webinars that are coming in the next weeks, and both of them also deal with future subjects that are related to it. The first one next week is about infodemia. For those of you who do not know the term, infodemia is an issue where we discuss information on COVID, sexual and reproductive health, and neonatal and maternal information. And the other subject is on how technology, emotional intelligence, and everything may help us in the future. To close this welcoming moment, I invite you all to look at this list of the coming webinars. I hope you can all participate, and I wish to show you a video on CLAP's past. We have made many contributions and we want to honor them. This video is a tribute to all those who have worked, from our founder, Dr. Caldeiro Barcia, to all the directors we have had. It's a tribute to their work, to their participation, to the participation of the teams that were here. So I'll leave you with a video and my thanks, and I hope you enjoy the discussion. We have very good guests, and I'm sure that you will love hearing them. Thank you very much. I'll see you for the closing words. Thank you.
Déjame ver a ver este. Uy, este es re viejo. ¿Esto de qué año es? No te sé. Junio del 60. Mirá, acá está, mirá. La contractilidad y la frecuencia cardíaca, ¿viste? La contractilidad uterina.
En los años 60 en Montevideo hubo grandes avances en la medición del bienestar fetal. Gracias a las investigaciones lideradas por Caldeiro Barcia y Hermógenes Álvarez en la Facultad de Medicina, lo que cautivó a obstetras y pediatras de la región y del mundo interesados en capacitarse en investigaciones en torno al parto. Estos adelantos también captaron el interés de la OPS, que decidió impulsar lo que se estaba gestando.
Entonces ellos deciden presentar la creación de lo que sería un centro de perinatología, que eso era el futuro de la obstetricia y de la neonatología. Y ahí se crea el término por primera vez perinatología, por esto es importante.
La Organización Panamericana de la Salud decide crear un centro de formación en investigación en Uruguay.
En ese entonces el problema de mortalidad infantil era un problema muy grave en la región. Era la parte más difícil, era mortalidad perinatal.
A mí me pareció un sueño cuando se me eligió para ingresar a este centro. Me pareció que yo iba a entrar a un lugar que era comparable con la NASA.
Y en ese lugar, Caldeiro, con su equipo, decenas de personas, decenas de becarios, cientos te diría, que pasaron por el CLAP, hacían investigación básica, aplicada al embarazo.
CLAP fue transitando de la investigación básica a la salud pública, un cambio que le llevó a registrar lo que ocurría en los servicios de salud desde la primera consulta antenatal hasta el momento del alta de la madre. Un proceso que, junto con otras acciones de cooperación técnica de la región, contribuyó a la reducción de la mortalidad de causas prevenibles en embarazadas y recién nacidos.
Pero el CLAP es la construcción colectiva que se hizo. Son 50 años de construir colectivamente con profesionales de todos los países, porque hay una saga. La saga es la continuidad de las personas con los valores, con la metodología, y en un proyecto que trascendió las fronteras de Uruguay y que se dedicó a la salud pública y que hoy en día tiene una presencia en todos los países.
Thank you very much, Dr. Susan Saruja. director of CLAP, for this presentation of a video that is truly moving, where you show CLAP in the history of maternal and perinatal health in the region, where it has supported the programs, guiding them, and improving health in our populations in the framework of public health. Without further ado, I also wanted to introduce now Dr. Bremen de Mucio, so that we may start the presentations. Dr. de Mucio will moderate discussion from now on. He is the Regional Advisor on Maternal Health from CLAP. Dr. de Mucio, you have the floor. Thank you very much to all of you. Thank you, Andres, for your kind words. I shall be very brief. I shall basically introduce three wonderful lecturers. First of them, Marcelo. I would like to see the plate with Claudia Sosa. Dr. Claudia Sosa is a gynecologist. He has a master's and a PhD in perinatal epidemiology from Tulane University, and he's full professor in the Department of Gynecology and Obstetrics, Clinic C, in the School of Medicine of the Universidad de la República in Uruguay. He's also a CLAP consultant, and nowadays he will make a presentation on some epidemiological aspects. The issue will be the contribution of birth induction in the increase in the number of cesarean sections. I would like to tell all participants that you may ask questions in the chat, and we shall consider them at the end. We shall divide them amongst our three panel members so that you may respond to them, and also remind you that we have not reached the maximum number of people we may receive, but if you know of anybody who cannot enter after we reach 500 people, they can join via the YouTube streaming. Claudio, please, you may start with your presentation. Good morning. It is an honor to be part of this webinar in the context of CLAP's celebration, to thank the introduction of Drs. De Francisco, Barbosa, and De Mucio for the introduction. And it is a pleasure to share this activity with Drs. Olsi and Sadler. In this 20 minutes, we shall talk about something for the short term. We wanted to show you an analysis that we carried out some years ago, and we have updated it now. And with the pretext of analyzing the weight to be born concerning our high C-section rate, we also wanted to show something that CLAP has been doing for years, since the 80s, with the perinatal information system, which is to analyze data of perinatal epidemiology and to apply it to a series of questions and evidence-based interventions. Some years ago, we published locally an analysis of a public sector maternity ward, the largest in Uruguay, with good data quality, 20 years data, approximately 7,000 to 8,000 births per year. And we wanted to see the C-section rate. This is the original graph in the paper. In 96, we had 15% C-sections in this maternity ward, which was high because it was a low-risk maternity, and it increased in 20 years, reaching 25, 28%, and it is now approximately 30%. It's a public hospital where the medical school trains its students. And in parallel, you may see in black that we observed that in 96 we had a 5% inductions of delivery, and we say induction is when we decide that for any reason, for perhaps a mechanical problem, there is an indication of induction, and it was 5%. And in those 20 years, it reached 21, almost 22%, a fourfold increase. So we saw a direct relationship between the C-section rates and induction of labor. This may be explained because of a difference in case mix, because, for instance, new peripheral maternity wards could have concentrated the low risk. So we step and was to analyze all the database regarding all the maternity wards representative of a country through time. So we could analyze different countries and different contributions, but we found that what we really wanted was something that would represent the whole country to avoid the case mix phenomenon, to study induction of labor and C-section in a long term. We found an ideal database through the perinatal information system, and we considered the base 2009-2018 through the Ministry of Health. We wanted something more regional, but the conditions was a long-term and a population that represents the whole country. We know, and there will be another seminar on the information system. SIP is widely used in Uruguay, used by all clinicians. It has a strength that clinicians, midwives, physicians, everybody feels it. Its weakness for research is that we miss some data and sometimes we have to make complementary analysis. Another important thing to show the representativeness of the database in Uruguay is, please look at the second column. These are birth certificates for the 10 years in Uruguay. Uruguay has most births at institutionals, and certificates cover then 99.9%. And in the third column, you see the SIP coverage. So the coverage for SIP is really over 90% coverage in every year, and about 96, 98% after 2004, highly represented country. And this epidemiological approach, we shall try to summarize it as much as possible. Going to such a rich database requires conceptual models so as not to go in a fishing expedition. We wanted to consider labor induction, which had been shown in a hospital, whether we saw that in the country throughout the period and whether that was maintained for the whole country to avoid case mix effects. The first analysis, which is a bivariate analysis correlating two variables, we can see that from 2009 with 36% C-sections in Uruguay, there was an increase reaching the very high rate we have now, 44, 45%. That increase was accompanied by an increase in labor induction, going from 14% to almost 20%. Statistically, that was significant. There is a high correlation. And in this very simple bivariate model, R square, which is how much does induction explain, it's 68% by the presence of induction in those patients who ended with cesarean sections. We wanted to see something more. You know the Robson classification for different groups, different population groups. There are 10 groups. I want to concentrate on the first 5, which are 80% of the population. Groups 1 and 2 are basically nulliparous patients with a single fetus term, encephalic. So it's ideal for birth. Number 1 is spontaneous delivery. And group 2 is the same patients with induction or elective C-section. The same happens with groups 3 and 4. Those are multiparous women. 3 is spontaneous labor and 4 C-section or induction. And finally, previous cesarean sections. And obviously in a country with such a high rate, we think this group would increase. And we wanted to see if there were changes in those 10 years among nulliparous, whether there was an increase, and the same in multiparous. And as you may see here in the strand graph, clear in red, group 1, in orange, group 2, there was a trend to decrease spontaneous deliveries in group 1 and increase group 2. And in blue and light blue, we see multiparous with the same effect, less spontaneous births or deliveries and more induced deliveries with a black line, which is the group with a previous cesarean section. So we clearly see a trend throughout the whole country, but not just one hospital, but a tendency to have more inductions within the groups defined by Robson. Moving one step further, this is very epidemiological and I don't want to bother you, but we want to see if causality is not associated to other elements because many things can happen in 10 years. We looked at several variables. We worked by 5-year groups, 2009 to 2013 and 2014 to 2018. And we looked at age, body mass index, since we are talking a lot about obesity epidemic, antenatal control, and something related to induction, which is the existence of different pathologies. And I stress some points. Regarding age, all this was significant. That's why I included it in the table. There was a decrease in teenage pregnancies that can be due to Rwandan policies regarding contraception and access to contraceptives, and an increase of patients of 20 to 34 and over 34. When we look at body mass index, I want to stress overweight, obesity, and morbid obesity that was 30.7% in the first 5 years, and it increased to almost 39%. And we see that antenatal control went down, the no control. Controls regarded by WHO as appropriate increased in a significant manner. And let's pay attention to existing pathologies, which for SIB is any pathological element in a pregnancy. It increased from 45 to 55%. I specifically mentioned diabetes because gestational diabetes background, that is, women who were diabetic, increased from 5 to 13%, and gestational diabetes increased. Perhaps this can be explained by age or the increase in body mass index, but it may be an artifact due to induction. But in recent years, the definition of diabetes has changed from 0.5 to 1.91 grams per liter. So we are talking of a new definition, and yet here an indication of induction with a lower glycemia, but morbidity is not really that high, and we could be discussing induction in those cases. Let's make our conceptual model a bit more complex to show you the final analysis. We saw that maternal age, the body mass index are increased that might affect pathology, and that all may be associated to a higher need to induce labor and cesarean sections. And there are two more variables, which is parity, which is predictive of the possibility of a vaginal birth. We know that multiparous women are more likely to complete their vaginal deliveries, and the other way around also. I do not want to make it too complex. This is multivariate analysis. considering urgent cesarean sections after induction of labor, not sections. So we consider the most important variables, and I wanted to show you induction of labor is one with the highest effect. What we saw in bivariate analysis remains here. It has a high contribution of induction of labor. Previous cesarean section, we know there is a higher likelihood of ended up with a new cesarean section. Adolescence, and this is adjusted to parity. It reduces the risk of cesarean sections, but age above 34 years increases it, as has been published before. Being nulliparous may be increased to higher rate of cesarean, but in 3 or more vaginal deliveries reduces the chance of cesarean sections. Finally, as we saw before, body mass index and maternity have a certain association, even independent of induction. So we might try to reach the different effects of our conceptual model, seeing that induction contributes to cesarean sections. There are direct effects of body mass index. For instance, we may see that in maternity wards where the difficulty of morbid obesity for an appropriate control reaches finally ends in a cesarean section. Parity may decrease or increase the chance of cesarean sections, but another variable we wanted to include, and we discussed this in club with Drs. Bremen de Mucio and Diaz Rosselló, is gestational age. We know it has important weight because the patient with a pathology that is not an emergency, but allows us to gain time, makes the obstetrician wait, for instance, with not severe pre-reached term, we do labor at 37, 38 weeks, and also gestational age might have an effect on the success of induction of labor. And here I show you this graph published by Spong in 2018 in gestational age, and it shows the risk associated to the time of interruption. As I gain in the studies, I increase the possibility of complications. As I move forward, I have a greater chance of a non-severe eclampsia to become severe, of a bleeding, of a scar from a previous C-section to break. So there may also be fetal morbidity that was unexpected, but it is also true that increasing the gestational age reduces neonatal morbidity and mortality associated to immaturity, and also the possibility of failed induction, prolonged labor, and cesarean delivery. So the obstetrician and the midwife has to work with this balance to achieve the lowest C-section. And here we bring an extra graph. It is the last one, where we see not a trend in 10 years, but the full base with age, where we see the possibility of induction, and at 41 weeks, which is the recommendation of not going on because of fetal health, and then we start interrupting, and we see that cesarean termination decreases week by week, but it peaks in the 41 week when we have an induction at 41 weeks. In that sense, our question would be, well, gestational age might be a reason why, when reaching 37, 38 weeks, I might have to induce dual pathology, but there may also be an effect that we see in the chart, that is, induction of labor related to gestational age may be more successful in the cesarean rate. It is not in the database. We cannot assess it with cervix maturation. What happens between 37 and 41? Induction increases, cesarean decreases, and that has to do with the Bishop score, which is cervical maturity or favorable obstetric situation for more successful vaginal delivery. If we apply this to all cases, and we decrease the number of previous cesareans, we see that this decreases. Finally, in the multivariate analysis, we said we should increase with another term, interaction. Does gestational age interact with induction of labor? Well, we didn't want to increase prematurity or immaturity, I'm sorry, but once we add gestational age, the effect of induction of labor is reduced. When we had almost 3, odds ratio went to 1.3. So there is a great interaction with gestational age. So first line of conclusions, and these are the final ones. There is clearly a higher cesarean section rate. There has been an increase in the induction of cesarean sections. The role of the gestational age for the success of vaginal deliveries is very important, so that balance between fetal and maternal risk and the need for induction has to consider gestational age to reach that success. There are population epidemiological changes that don't account for the changes of cesarean sections, but issues like body mass index and obesity, maternal pathologies, particularly diabetes. And there we pay attention to the role of epidemiologic surveillance, because cesarean section rates are very high, which make us sad, but there are good data. And in these 10 years of CLAP, we just wanted to show you some interventions that are evidence-based. And for instance, the rate of episiotomy, you know that we try to decrease episiotomy. And when we see that in the nulliparous, it has decreased from 50% to 35%, knowing that evidence says that in randomized studies, 30% is the rate of restrictive episiotomy. It is a positive change. New generations are incorporating this intervention. What happened with late clamping of the cord? It has increased. That is good evidence, from 56%. So 90% of deliveries have late clamping of the cord, which is a recommended intervention. Another one that we have worked for years in a while is active management of placenta delivery, because this was an important cause of maternal complication. It has increased, and it is amongst values being promoted.
That is, and going back to the role of CLAP in a region and the significance of epidemiologic surveillance and the need to be able to control, I think that this is going to be very rich using evidence-based interventions. And it's important to consider the data for decision-making, data collection and analysis, and their analysis to somehow implement public policy to improve the health of the population. The cesarean section and but not just thinking of cesarean section, but also other factors that have to do with the health of populations. Thank you. Thank you, Claudio. Later on, we'll have a chance to discuss some of these things and also to answer questions that people sent during your presentation. Now I wanted to introduce Yvonne Olsa, and before I introduce her, I wanted to thank a colleague of WHO who is pushing forward the everything vegetarian section, Ana Pilar Ventran. She put us in contact with Yvonne Olsa, and it's a pleasure for us to have her with us. Yvonne is a physical doctor. She's a child and a perinatal psychiatrist, and at present, in addition to her vast career, she's the director of the European Institute for Perinatal Mental Health in Madrid, Spain. Claudia, please, could you turn your camera off? And now we'll invite Yvonne to present, to give her presentation. Hello, good afternoon. My greetings from Madrid. My compliments to Club for their anniversary. Let me thank the invitation, especially Bremen de Murcio and our dear colleague Ana Pilar Retran, who's in Geneva, and also thank this opportunity for having a deep, an in-depth discussion on the long-term consequences of the way we are born. This needs to be multidisciplinary, and as a child psychiatrist, I really appreciate this opportunity of talking to this audience. I was asked to discuss a complex topic, and there will be people that will that people may wonder what is the relationship between these things. But I always like to speak of John Bowlby, a child psychiatrist that 70 years ago was invited by the WHO to draft this report. It was so important on the care of orphan children. It was the basis of the bonding theory that enables us to see the long-term consequences of everything that's going wrong at the beginning in of our lives. Now we know, and we are investigating the bonding knowledge, and we know that the interaction with the mother and the beginning of the bonding is of utmost importance. And the early and this bonding leads to significant neuroendocrine, has an impact on the neuroendocrine symptoms, and the disorders of bonding will disrupt sexual behavior, reproductive behavior, social relations. That is, it has a great impact on the future of civilization. So, speaking of the way we are born, we need to understand that our view of childbirth has changed, because now it is a neurohormonal event, and this has great implications, and it changes the way we provide care at childbirth and think of the longer-term consequences. The signs that the child is ready to be born, it's important to highlight that the hormones that trigger the childbirth, labor, and the exit of the child, oxytocin, that directs everything, will generate very significant effects in the brain of the mother and the baby's brain. And all along the delivery, there's a significant dialogue between the two brains, and this dialogue goes beyond the childbirth. These neurohormones of the physiologic childbirth, the women that go through this experience produce disruption, derangement of causes. Now we are speaking with the women that have gone through it, and we know that this is and that women when in labor see things differently, they feel differently, and this psychological status is very sensitive to the external environment. That is why it's so important for the people working at this to understand this. And all this implies that when the baby and the mother meet for the first time, the two brains are in a neurochemical scenario that is exceptional, that only happens if you go through a physiologic labor and childbirth. It is impossible to reproduce it artificially, and both the mother's and the child's brain are full of oxytocin, but also other hormones, and this will lead to a number behaviors. And this psychological, um, this we have seen that there is a transformation. The women with a good physiologic uh, childbirth feel reassured and empowered, and they feel like breastfeeding. And we know that because of the effect of oxytocin, um, childbirth or delivery is a social event. It's not whimsical. It's a physiologic need, and this has great implications. But now I'm going to focus on this part. What happens in the brain of the newborn? We now know that during childbirth, there is a phenomenon that we don't understand well, and that is that oxytocin switches the GABA system in the brain of the newborn, and this has to do with the electrical transmission in the brain. Apparently, it's a neuroprotective effect, very striking, and then we'll see the consequences. We know that right after birth, the newborn has the catecholamine levels that are higher than any other moment in time, even us adults. And this has great implications. And things happen with vasopressin. And all this gives an imprinting effect. So, and we know because neuroscience tells us that what the baby expected, this encounter with the mother goes far beyond just beauty. It's a health issue. So the mother's body is the habitat of the newborn, and it is there that the newborn will be able to develop these behaviors. So to know the sequelae, there are three concepts that are very important in neuroendocrinology that are important. The first is the existence of critical periods in neurodevelopment. This means that the consequences are irreversible for a lifetime. And there are other periods that are sensitive, that are more flexible. They are not, so we need to understand neurohormones. This is very long to explain it here, but there may be two effects. One is activation, that is the classical effect of hormones, of uh, triggering a cascade, but may also have an impact on development because it organizes a development uh, trajectory. And then we have the windows of development. And now we know that in the fetal development, there are times of fetal programming that has a lot of implications for the adult life. We need to understand that birth and delivery are critical for neurodevelopment, and this is now being studied. These are the signaling events. And we already knew this. This is an old study, 2009 in Russia, that showed that the variables of being skin against skin with a mother right after birth favored the interaction and the sociability of the mother and the baby that would be more empathic and more reciprocal. Now, where are we? We are developing this model to understand the potential difference between this ideal childbirth. To your left, there's a healthy mother that has a spontaneous effect, that there is a full-term baby. And what happens in all the rest of the scenarios? We need to be able to think of all the situations as neurobiologic scenarios that are disrupted. What happens when mother and baby are separated right after birth? What happens, for instance, now during the pandemic with the coronavirus? They are isolated, and sometimes the mothers won't see their newborns until a few days later. So what happens in the brain of this child? So this is like a 1,000-piece puzzle. We're trying to understand this, but we need to, for instance, one effect would be premature birth or the effect of stress in. And the important thing to understand is that programmed cesarean section with no labor, from a neurochemical point of view, that is very different from the emergency cesarean section, where there's already been some labor. But we also have to think of the use of anesthetics or the using of synthetic oxytocin. how these substances alter the child or the mother. Notice that in many cases we'll have an accumulation effect. We're going to have many situations. Um, we are going to both in the mother and the child. This will have an impact on both. So we are trying to understand this to show the way of where we have to investigate what happens with these disruptions at the beginning of bonding. How does this affect the brain's development and the mother's behavior and the mother's mood at the beginning of the bonding and during breastfeeding? So this is very complex. And for today, I'm going to focus on what I was asked, that is the long-term consequences. And we know that cesarean sections, it's been proven that they increase the risk of presenting diseases such as asthma, rhinitis, allergies, type 1 diabetes mellitus, obesity, celiac disease. And we know that there may also be an increase of psychiatric diseases such as the autism spectrum disorders. This is there. There are changes in the speech, in playing, and also in attention deficit disorder, and there's also an increase of the risk of psychosis. So, what do we see of studies in animals? So, most of the studies are conducted in rats, and in Madrid, they published this paper that is one of the first that appeared, and we find that they found that in the mice that had that were born in adult that were born with cesarean section, where they got to adult age, they showed significant deficits in spatial memory, disorders of behavior in a stressful situation, and they had lower levels of UCP2, that is a neuroprotective of the hippocampus. And it is very relevant because it goes beyond, because they compared several brain areas in mice that were born through cesarean section and the normal delivery. And there's a reduction of the budding of neurons and apoptosis. Those that are born with cesarean section, there's no budding, and it doesn't just reduce, but in some cases it increases. And especially in some, they are so significant as the hypothalamus that regulates the relations between the immune system and the nervous system. And there were also disrupted behaviors with the small rats and a higher weight at weaning. So these are consequences at weaning. So these authors suggested that the cesarean section resulted in persistent disruptions in the brain of the mice. So the Academy of Sciences in the United States published this reflection. We are going to, they say, we need to be cautious and be very mindful when we choose to use the cesarean section. And although it's a life-saving procedure, it should be used cautiously. This paper was published in October 2020, and we confirm this is a very good study, and the mice that were born with cesarean section had social deficits, cognitive areas, and that lasted to adult age, and they saw all these changes, recognizing the mother's social behavior, social recognition, anxiety, the effects on the hippocampus, etc. So what do we know of humans, of newborns? So I won't mention the mother's part because that would be for some other meeting, but we conducted a study in Puerta de Hierro that we published in 2012, and we saw that the newborns that were born with through cesarean section had a different response to separation from mothers. We filmed this. They didn't seem to protest and they barely cried. So in this, we investigated this one, but the main study is this one in 2019 of the honest group, where they compared the behavior of the brain in 2-week babies born through cesarean section or natural childbirth. And here you see the differences in the brain in the children without with cesarean section, and there are differences in important areas. And the author says there's a reduction of the microstructural integrity of the white matter. There's a weaker functional connectivity at rest and less myelinization in certain areas in the brain. And then they studied these same children at the age of 3 years, and they found that there the differences disappear almost. Here they point out that these more functional and morphologic differences are relatively transient. So they didn't persist at the age of 3. However, they were evident at the beginning. The other relevant studies, here you have a listing that find this association with intellectual disorders, more changes, more risk of neurologic disorders. And in a recent study, they didn't find it so much, but we are just beginning. And here there's a lot that we need to understand. This study is very recent. It was published in October, but I invite you to read it because it gives a very clear explanation of what I just told. And it's evidence-based. And the conclusion of this article is that these differences in hormone signaling, this neurohormonal scenario that is so different when there's a programmed cesarean section, may have impact in the neurodevelopment of the newborn. Different authors are trying to investigate the mechanisms through which this takes place. Why should cesarean sections leave sequelae in socialization and even in adult age? This is subject to a lot of discussion, but apparently there may be a number of factors that are involved. For instance, there may be changes in the vasopressin receptors or sexual dimorphism. We know in animal studies that the effects may differ in males and in females. So in some of these cases, we see that there's a difference depending on gender. The changes in the switch GABA in brain, when it does not happen, there may be an increase of the autism spectrum disorders, and there may be these children may be prone to some disorders, and the immaturity of the brain. So the cesarean section is not the same when there's a spontaneous labor or when there has. Another mechanism that may interfere is the changes in the mother's behavior. This would be another presentation. What happens in the mother's brain when there's a scheduled cesarean section? For instance, the changes in breastfeeding and the swelling and the intestinal microbiota is one of the current stars. When the child doesn't go through the mother's the vagina, then the baby is not colonized with the intestinal microbiota of the mother, and this may have an impact on the microglia and the transmission of inflammatory substances in the brain. And this might be one of the potential ways of thinking of therapeutic interventions. So summarizing scheduled cesarean section with no previous labor implies an omission of critical events for neurodevelopment. The brain sequela of cesarean section may appear years after birth. In animals, well, they did it, the studies were done in rats in 3 weeks, but in humans it may happen years later. So there may be consequences in life after scheduled cesarean section. The effects may be seen at puberty. But puberty is a window period and it's a critical period to development. So it's also a period for healing some of these early disturbances. And here we can deduct, on one hand, the importance of preventing and avoiding unnecessary cesarean sections. And let me make a comment. Of course, prevent unnecessary cesarean sections, and the WHO is doing a wonderful job, limiting the recommending to limit them to the most possible Robson's classification. All that is important, but I wanted to discuss this, how to minimize. We know that there are cesarean sections that are necessary. We are aware that many mothers or fathers that had their children with cesarean section, myself, all my 3 children were born through emergency cesarean section. So sometimes women are worried, saying, well, I was told that I need a cesarean section. I don't want my child to have problems because of that. Well, in a study, they saw that the neurodevelopmental differences in the mice that were born through cesarean section were corrected if those mice were raised with other mice that had been born naturally and with probiotics, and they receive probiotics. So we should need cesarean sections to be as physiologic as possible, to minimize, to reduce to a minimum the difference with labor and childbirth. We need to understand that accompanying the mother is of utmost importance, and we need skin against skin. Coronavirus cannot be an excuse to separate mothers and newborns, and to take care of maternal mental health during delivery, and the fathers to support maternal breastfeeding, to promote oxytocin and to enhance oxytocin and low stress environment, and then screening and early treatment of early disorders of the neurodevelopment. And here you have a poster indicating the importance of skin-to-skin contact. So that's all. Now I say goodbye with this picture of our colleagues, and I wanted to thank all the professionals that are working so hard, respecting and accompanying the childbirth. And I'll be very happy to listen to your comments, and I'll send you my presentation with all the references later. Thank you, Yvonne. Excellent presentation. As we had already heard some of yours, and they're all brilliant. And although in the chat, we see that in the chat, there is a huge number of questions of people that are very worried of the potential implications of what you said. I want to rescue the colleagues that are participating and tell you that if you put the questions in the chat, it is very difficult for us to get them. There's a specific chat that is the Q&A chat. So please, whenever possible, although we are always looking for questions that may get missed in the chat, try to use only the Q&A platform to ease our work, because I don't know, we're going to be very strict about time, but certainly there will be many, many questions unanswered, because there's a cataract of questions both for Claudia and for Yvonne, and we are very happy about that. Just as I told you that I wanted to thank Ana Pilar for giving us the possibility of having Yvonne. We must thank Yvonne because she contacted with Michelle Maria Sadler. Many of you know her. She's a social anthropologist who works with gender and medical anthropology. She teaches at Adolfo Ibáñez University. She's a Chilean, and she's going to speak about the impact of obstetric interventions in the short, medium, and long term by the women. So welcome, Michelle. You have the floor. Please, let's try to remove Yvonne's picture from there, although we're enjoying it, of course. Thank you. Good morning. I don't know whether you can see me because I don't see myself there. Yes, Michelle, everything is fine. Good. So good morning, everyone. Thank you for the invitation. And Yvonne, as Bremen said, thank you for recommending me to be invited. And I'm very, very happy to include this topic because I think that it was not so important. That is what the women feel. When I was listening to Yvonne, I said, well, this is a paradox that everything that we are shown, the randomized studies and physical and the scientific evidence, this is what women have been saying for so long. So I invite you to hear the voices of women and to see the consistency with evidence and everything that we are discussing today. I speak as an anthropologist and geographist, and that I've lived for 20 years observing childbirths and listening to the testimonies of women and healthcare professionals, and seeing the pain of women in the healthcare teams where they face stressful events. So, as a brief framework, let me just say that the objective of the Sustainable Development Goals and the strategies of women and adolescents go much further. So, we speak of seeing the greatest potential in life, not just for us, but future generations. And here, the experiencing the quality of life is absolutely relevant as expressed in the recent recommendations by WHO. Look at their names. They are for experience of a positive childbirth. Both these recommendations and the initiative of the International Childbirth Initiative, including FIDO, they focus on a respectful experience, the quality of care for the pregnant women and newborns of the WHO. If you look at these two columns, they weigh the same, the evidence that comes from practice and the feelings of women. And this includes the effective communication between users and healthcare providers.
If we think of the quality of care, we have to look at the negative counterpart, the lack of respect, the abuse, which we are paying far more attention to now. In 2010, we had the first systematic review by Pauser and Kiel. Afterwards, we had another one by my colleague recently, and we have many studies of organizations, academicians, wondering what is happening, why is this happening throughout the world, and we try to eradicate this. And the 2014 statement on the prevention and eradication of a lack of respect and mistreatment during delivery care, a document of the 2019 report on the access and importance of obstetric violence as a violation of human rights and as gender violence. It's very important, and it gathers experiences of women throughout the whole world. And if we look at Latin America, an important thing in our region is that since before the Anglo world, we already consider this as structural and gender violence. This is a 1998 paper by Brazilian colleagues such as Denise, who were already talking about reproductive violence, or the Mexican colleagues Castro and Erviti, who also from the beginning of the millennium have been discussing this as reproductive rights. There are many researchers who in recent decades, I do not have time to name them all, but there has been a visibilization of the problem. And in Latin America, a different concept arose, which is obstetric violence. And it tries to focus the problem at the structural level of a cultural relationship level. It's a medical system, biomedicine, which is a cultural system which reproduces gender ideologies. This conceptual discussion you may find in a paper we wrote with different colleagues from other countries, where we include this analysis I have made. So we are at a time where it is clear that women's experience is central. And how do they live? What is the impact of obstetric care in women? Let's listen to some stories, considering that obstetric interventions, the technical aspect cannot be separated from the way in which you treat and people live it. And I will bring you some examples of Chilean women, but they are representative and very similar to what we find throughout Latin America and outside the region. This is a survey we made in Chile, 2017, about experiences of birth in a sample of over 11,000 women with an open question where you could have stories, long narratives, of which we have 8,600. So there are thousands of pages that we keep analyzing. We have made several publications based on this study, and we are still working. So I'm bringing some of these. And since we have very little time, I will consider the two extremes in the gradient of care. There were experiences of women who feel comprehensively taken care of, and some who feel mistreated. When a woman feels she's been taken care of, she will say things such as this: he or she was very respectful. We felt the protagonist of this very important time. I felt empowered and happy because I was heard and accompanied. It was a wonderful experience, perfect, full of love and contention, a professional team that was patient and waited the process time. I was always accompanied. I had my son with me, skin against skin, for almost 3 hours. We see that in these stories, the evidence-based practice is going together with amorous, careful care. And not always is result what we expected. We shall not always have a live baby or a healthy baby. This is a story by a woman whose baby died, but in spite of everything, she felt she was well taken care of. The team was very humane with our situation. They accompanied us from the beginning. Instead of taking me to a recovery room, they left us in pre-birth after the C-section with our dead son and our family. We felt protected and taken care of in our pain. And the word care was always repeated. So we see that the experiences of comprehensive care are the communication and affection context that give a meaning to the experience, and they allow for incarnated epistemic agency. In comprehensive care, you find interactive dynamics of participation, which are spoken of from us, we, the family and the health team. There is a moral, existential sense of care, which is based on a commitment to the others. And this is different from the negative experiences and almost traumatic experiences. And here we go to the other end of the spectrum. I do not have time to review all that we could say, but we have spoken about induction and cesarean sections today, but there are many routine interventions that are still being practiced and are unnecessary, of course. And we rarely think of the profound damage and impact they get. Vaginal attacks that are unnecessary and they make women feel humiliated, insignificant. Many women say they felt exposed, violated, that too many students went by, they had people looking at them. Movement restriction, lithotomic position produces pain and comfort, anguish. We know it has no physiological. The Christelle maneuver that should not be performed, still performed. It produces anguish. I was choked. I still dream about it when I'm depression. We have quoted Dr. Caldeiro Garcia, but 40 years ago, we already said that with the exception of being have from the feet, the tectonic position is the worst conceivable position for labor and delivery. Why do we still perform this against evidence? Episiotomy, we also minimize it. The effects are minimal on women's sexual life. They produce pain, uncomfort, difficult to urinate, to pass feces, to look after the newborn. It produces long-term damage. And I also remind you words by Dr. Wagner in letter to the Lancet. He asked, can the Lancet help to deviate support of feminine genital mutilation in its modern form, episiotomy? And Dr. Girard answered, the current acceptance of episiotomy may be related to the denial of obstetrics of evidence-based medicine. Dr. Olsen talked about the impact of separation of mother and child and the lack of company. Delivery is a social event and a neurohormonal event. Think of the pain and anguish that we feel being alone and separated from our newborn. A woman said, I don't know what to do to go back in time and become empowered to defend my child, not to be separated, to hold my love, holding my hands. All these experiences, particularly the ones in the negative extreme, have some common events. The woman did not feel like a subject, they feel like a piece of flesh, like a table, an object. I felt like an object, that it was a thing and not a person. And we could say, is this an exaggeration? But no, it's not so, because if we look at the frequency with which unnecessary interventions are practiced and for which women report these feelings, we see that it is an enormous problem. These are results of our survey, but in recent decades, continuous fetal monitoring and synthetic oxytocin have increased, cesarean sections also. And these are linked with this chain of interactions that produce a need for other interventions. This is also from our survey in recent years. Women who felt left behind or made silence were 43% public services to 20 in private sector. Women who felt they had no information, 71 to 52%, who had no somebody with them during delivery, 61 in the public services to 21. And this shows the high frequency of this poor practice, that negative experiences are particularly acute for women in marginal situations in society. And we know that those women who are most vulnerable, who should be taken care of with greatest care, are again the ones who receive less care. So how do they end up? My vacuum was enormous. It took me 40 years before another child. I requested programmed cesarean section not to undergo another delivery. I don't want to have a baby ever again. I feel I was marked forever. The damage to my person was irreversible. The wound remains open forever. It is part of the memory of our children's delivery, which cannot be erased. It is something that does not disappear. It's difficult to recover from this experience. experiences lived as traumatic, you lose confidence in the world and other people. You lose a recognition of the fact that we are interdependent subject, and traumatic experience is frequently followed by fear, nightmares, anxiety disorders, depression, or post-traumatic stress, with effects that can be devastating in the capacity to take care of the newborn. Post-traumatic stress symptoms after delivery may have a negative influence in maternal perception of babies, with potentially negative implications for the mother-child implications, as has been shown in different studies. And if we think of how many women suffer disorders like this, different studies show that approximately a third of women have some sort of partial or incomplete syndrome of post-traumatic stress, which in different systematic reviews, like the ones I show here, ranges from 3 to 4% of women with post-traumatic stress, and in women who are of high risk, it's 15 to 18%, and in obstetric emergencies, it is higher. In France, women who had emergency hysterectomies, 64% had high symptoms of post-traumatic stress. So I ask you to think of the factors leading to this interventions, mistreatment. The meta-analysis by Bomek shows that after depression with pregnancy, fear of delivery was the most frequently present alteration. Sometimes they say, well, you have no capacity to bear pain, or what is your problem? But let's think of our own negative experiences, those of women around us. Let's think of the cultural construct of birth as a risky, a very painful event that cannot be dealt with, the pathological construct of the feminine that is very important in our culture. So the question would be how not to be afraid of a delivery. So we could reconfigure that fear as fear to abuse, to an excess of obstetric interventions, abandonment, loneliness, to be treated as an object. And how many obstetric emergencies are the result of intervention chains that are not based on evidence. And if we think of severe transformations, so we should insist on the importance to work on evidence and recover agency and care as a comprehensive thing in an amorous, compassionate way. It is imperative to pay attention to comprehensive quality of care, the experience of women in the families, and although I cannot deal now with how do we care of health teams, how do we take care of them so that they are able to care? But we deserve to receive care, because otherwise we shall not be able to take care of others. So thank you very much. And like Yvonne, I leave this presentation with all the bibliography.
Thank you, Michelle. I'm sure that if we were in the old normality, we would be hearing an applause for all the speakers. Well, of course, some of these topics are controversial, but what CLAP wanted to do, since Caldeiro Garcia founded this center, is food for thought. We don't take sides, not in favor, not against, but we are always in favor of women and children and health. But we are always also in favor of the teams. So with all these elements and others that we couldn't bring today because of lack of time, the idea is to build a better future for all. We went from the crude epidemiologic data, then the psychological and behavioral impact of cesarean sections, but at the end, Michelle brought us the human dimension of women during birth, during childbirth, and I think it's important not to forget it. If we were strict, our webinar would finish now, because this is exactly the time that was scheduled. So if you have to leave, we thank you for your participation, but I think that the most important comes now. That is the possibility to exchange questions, uh, some of them before the meeting and others that appeared later. All the presentations, all the webinar will be recorded and all of you will have access to it. So from now on, we're going to try to be as concise as possible. As a matter of fact, some questions overlap. We are going to try to move forward with the Q&As with those that are willing to come with us. First, we received a question prior to the meeting and we wanted to take it to Yvonne. Scientific evidence has confirmed that the way we are born has an impact on all our spheres. Are those are the reversible effects, but it would depend on what happens with baby. My girl, who's now 2.5 years, and we're going to read as many questions as we can with no biases or censorship. She says, my baby remembers the time of a childbirth and she didn't like it. Is it possible for them to have such a level of awareness? Yvonne, thank you. Thank you for, well, this is a very controversial question. We have many accounts of parents that say that their very small children have mentioned details of the birth that we can't explain with the memory model that is based on the central nervous system. Apparently, at birth, we don't have that language development, but we have our body memory that is well developed. And these may be body memories that may later on, you may find words for that. So as adults, we keep a record of very early experiences. And there's a very interesting study in neurosciences, and I'm not an expert as I don't fully understand it, but apparently the new models of understanding of the human thinking are not so much related to the central nervous systems, and apparently they are trying to apply quantum physics models to try to understand these experiences. So I think that today we can't show scientifically that people may remember their births, but I am aware that there are many accounts of girls and boys, and even Winnicott, the child psychoanalyst, said that children played re-experiencing the births with details that they shouldn't know. So I think that maybe in 30 to 40 years time, we'll be able to answer this, but I'm very interested in this. Thank you, Yvonne. Now, as you are there with the microphone, I'm going to give you some brief questions, although the answers may not be so short. One of them says, so if my child was born through cesarean sections, can't we do anything to change it? And will the child be a psychopath as a adult? Is it are there any recommendations to help recover the child of the negative effects of cesarean section? Do you know about skin diseases? Today there's a lot of dermatitis in babies. I guess it's multifactorial, but maybe the first contact with the mother may be the most important. Well, thank you for all these questions. I understand people's concern, but please, what we see is studies that you can't draw these conclusions. Of course, you may have a nice bonding with your newborn born through cesarean section, and of course, you may be born through cesarean section and not to have any psychopathology as adult. Please clearly understand that. And always, and this is what we learn as psychotherapists, almost always you can heal. Healing almost always is based on loving mothers and fathers that are worried because of the consequences of the birth of our children. Since we have uh, sometimes healing an uh, is a loving effect, and feeling the contact of the skin. You can have it, of course, at birth, but many more times in life. Breastfeeding is wonderful to promote oxytocin, and breastfeeding is not just a way of feeding, but it's also a relationship. And skin with skin is very, of course, it has an impact with the health of your skin. The more we enhance physiology, the better it is. But I think that we need to consider that breastfeeding is slowed. The children that were more premature or had more damage, of course, will need more prolonged care. I think that socially we have to think of how to provide more help to mothers and fathers and families at the beginning of life, because it has a huge impact. But please don't feel anxiety because of my talk, because you can heal, of course, but it's important also to prevent. And that's why it's important to transmit this message. Claudia, I'm going to ask you some questions that we received. My baby was born at home. Then I went at the hospital because I was bleeding. My baby was taken to hospital just in case. And he was at a newborn unit just because it was protocol. Was that necessary only because the baby was born at home? And I'm going to ask more questions. Are there any changes in induction, either mechanic or with drugs? There's one that is a bit longer. It says, I'd like to ask a question. Do you have data on the information given to patients and their consent in those interventions, or if there are claims? Have you correlated the statistic results with the data of perinatal mental health? Have you talked with perinatal health? Um, do you consider what postnatal controls are necessary? Do you think that these poor results are due to protocols that need to be changed, or are they related with personal criteria? How can we change all these data? Rosa killed us with all these questions in just a brief chat. Do you want me to repeat them, Claudia? No. The first one was um, childbirth at home. Well, she mentioned bleeding. Bleeding. Well, if the newborn, if the usually, even if the patient, even if the child was born at home, there are no elements to separate the child from the mother. Not usually. So if the mother has to go to the hospital because of a complication, and she's taken to rooming in to solve the mother's problem, but you don't separate them. Are there any changes in induction, either mechanic or with drugs? If we look at the database, we can analyze something because we have oxytocin and other methods, but we don't have the separate, we don't study them separately. From a clinical point of view, let me tell you that in different places there has been a change, especially with mechanical methods, trying to use probes so as not to use so many drugs, and trying to mature the cervix with mechanical methods, and then to have induction with the oxytocin. So there have been changes from mechanical. But all this, thinking of an induction when it is indicated, because we have to avoid childbirth needs to be spontaneous, and you have to leave it as normal as possible within the parameters. No, when there are comorbidities, of course, you won't ignore a gravidic pregnancy, lithiasis that can lead to the fetus, the death of the fetus, or an unsevere preeclampsia at week 42 could be harmful for the mother and the child. So there are reasons, but there must be clear reasons. You don't have to be light in the indication or extra medical reasons that are not appropriate, or such as individual reasons of the patient or the obstetrician. Claudio, let me repeat some questions. Do you have information on information given to the patients and consent of these interventions? Are there any claims? Well, we don't have it of the database of Uruguay, but there is increasing requests for consent for cesarean sections, and some of them for also for normal delivery. Do you have the statistics of the problems of with perinatal mental health? I think she said in the long term. Well, I imagine it's in the long term. No, because yes, it's long-term monitoring would be ideal. The Scandinavians that give a life certificate and then related to later events, we don't have it. From the epidemiological point of view, everything that we do is in the short term. Now, let's ask some questions to Michelle so she can participate in this process of Q&A. I know that it's very difficult to handle the huge number of questions that we have, and we'll have to cut this. Based on your comments, shouldn't we consider some of the things that you said as malpractice rather than gender violence? Feeling a thing. That could also happen if you are being removed the appendix. And she congratulates you for your presentation. And I'm also going to show you another. Why should we go on with these interventions despite the abundant evidence against those interventions that are so iatrogenic? Why is anesthetic considered a violence when there is consent? Because if you try to remove pain, that shouldn't be violent. Thank you for your questions. First of all, when it's other interventions, I think that they called appendicectomy. I don't know whether you can compare it with birth and delivery, labor and delivery. If I go to for an excision of a tumor, or for instance of a tooth, here we are speaking of something that is a ritual in all the cultures that we know, and it has other components. I think that we have to see the magnitude. It's not the same as other medical practices, and maybe this is something that happens in biomedicine as we study the potential complications and the disorders. We tend to think of it as other conditions, but I invite you to think of it as a normal right of welcome to new human beings that has other dimensions, and that we need to think of all those terms. Of course, you always need to treat the patients well, but this is a different focus. And why should we cross it with gender violence? Because the forms of abuse that are identified, and I'm not the only researcher to say it, but when providing care at birth and sexual reproductive health, it has a lot of similarities with what happens in gender violence. And they are expressed in a specific way on the woman's body. The sexually charged jokes or comments. There's a conception of the female body that has been studied by many social scientists that is different from what happens to other interventions. So I think that there's a very interesting focus to consider and to be able to understand it in these dimensions that we are discussing. What was the other question? Oh, why do we continue to practice interventions? Well, that's the most complex question. Why, if we have known for such a long time that some of these practices are harmful, why do we do it? And we can think of anthropology. When some practices are deeply enrooted in a culture, it takes very long to change it. And well, when I'm speaking of a ritual as a shamanic, the childbirth is a ritual, and it makes culturally sense. And it's difficult to change those rituals. So I invited you to make a structural analysis. How are we training doctors and healthcare professionals? What are the paradigms focusing on physiology and enhancing that, expanding that view? And finally, anesthetics. I don't agree. The question was why it was is it considered violence? I don't consider it violence. One of the wonderful tools that can be used whenever necessary, and if the woman wants it, because here we're focusing on the woman. If she needs anesthetic and it will be of help in delivery, then if the woman doesn't want it, then it's important to put that need in the center of care. And of course, it's important to offer both pharmacologic and non-pharmacologic techniques for the relief of pain. We lost you. Until pain relief, yes, we heard you. Now, so we have a lot of questions. Really, it's impossible to answer them all. Many of them are, there were many questions about Yvonne's presentation, and mothers can have children that gave birth to children with cesarean section, or doctors that are worried about the well-being of their patients. But I think that Yvonne was very clear in her presentation. There are very interesting questions, as if this is due to problems in bonding or not having been in contact with microbiota. It's impossible. So you see that we have more than 60 questions in the chat and 52 questions in the Q&A session. We should think of some way to respond to them. But it's also important to think that maybe you should answer them, looking for the evidence for this, and send us questions. And I must say that many of the things don't have a response for us, because in some cases ask us, sometimes they ask how from CLAP we can change situation at birth. If we had managed to do that, CLAP would no longer exist, because everything would have been solved. But we need to continue to work, because today we didn't touch upon an endless number of variables that have an impact on the conditions. So before giving the floor to the director, Susan Sarruya, I wanted to thank you, the three of you, for your concern and for your efforts presenting these presentations, because of the warmth with which you did them, and finally, because of the technical skills and capacity, and all that supported us this time. And to answer some questions, let me tell you that all this will be recorded in the link that you have at the beginning, but those who have registered, I've sent them via mail. So, thank you, Bremen. And really, in the name of CLAP and all the team, I have no words to thank you. Claudio, Yvonne, and Michelle. Those were beautiful presentations. We wanted this type of discussions in the webinars, reflections, questions, concerns, things that we have to learn. I think that the three of you have succeeded to bring you brought childbirth that is such an important image for our culture that we could debate it for hours. It's true that there are many questions and many comments in the chat, but people are very happy, so we are here still. This is a very nice celebration. So, and I'd like to say something of each. Claudia showed how it is possible in a country to be able to see the evidence. So having, for instance, whether we need to consider higher body mass index or when we have good data, and that is done by the SIP, by the SIP, so we can show you the evidence and show you all the data. So this is one of the topics that we need to see with urgently in the country. Data need to improve so that we can ensure the best practice at each facility. I think that I wanted to thank all the doctors, all the speakers, because usually we don't consider many of the topics of what happens with the woman, what the woman feels, what happens with the baby. Sometimes people may say, well, I had to proceed to a cesarean section, and sometimes they are worried, but maybe with Bremen we could organize another meeting to discuss the impact of these things. And yesterday, there's something that we don't like for the future. We don't want in the future that a mother from the time of this time that needs to be so beautiful of her life to leave sad, or that may or for which she may not want another pregnancy. In this celebration we are very happy because the guests did a very good job. We had more than 400 participants in the Spanish room and in the other rooms too. And I want to hugely thank somebody that has devoted their life at this time. Bremen is more than the advisor. He is passionate about the health of women and mothers, and he devotes his life to that. And all the team, Ana Artigas, and all the team that she coordinates so that everything will come out fine. And now I invite you to know the present of CLAP. We have a very nice present, another video that shows some of the most important times of CLAP now. So thank you all for helping us, and to thank all the team and you who have been our guests. So, goodbye. See you next Wednesday. Goodbye.
Siempre fue un sueño trabajar en un lugar donde se puedan hacer cosas que marquen la vida de las personas. Y creo que el CLAP marca históricamente la vida de muchas mujeres y de muchos recién nacidos.
Durante estos 50 años, CLAP ha atravesado distintas etapas, acompañando hasta el presente las necesidades de la región para mejorar la salud de las mujeres, las madres y los recién nacidos.
Se fue migrando desde la investigación básica, la investigación esencial, a la investigación en salud pública y a la implementación de programas en salud pública.
En ese camino es muy importante la acción histórica del CLAP en el desarrollo de los materiales de capacitación, los instrumentos para la atención.
Durante un periodo de tiempo el CLAP se dedicó específicamente a hacer medicina basada en evidencia. Producíamos publicaciones para que le llegara a la gente en su propio idioma con las cosas más actuales.
Las investigaciones del CLAP permiten desarrollar buenas prácticas basadas en la evidencia que luego se trasladan a los países de la región de las Américas.
Lo que tratamos de hacer es encontrar a los docentes de medicina, de enfermería, de partería, para que sean los primeros que se entrenen.
CLAP ha expandido el CIP no solamente en términos geográficos, sino también se ha expandido a diferentes subgrupos, como por ejemplo recientemente se ha creado el CIP COVID-19.
La OPS siempre trabaja para lograr la salud universal. Este sueño no se alcanzará sin contemplar las necesidades de las mujeres, las embarazadas y los recién nacidos. Mediante la labor del CLAP, la OPS trabaja para que este sueño se haga realidad.
Duérmete mi sol, duérmete pedazo de mi corazón.